So this workshop here is the one on immigrant populations, specifically Latino and African communities. So we're about to get started, and we know this is a pretty big room. So to make it a little more intimate, just to make it a little easier for us to kind of conversate and make it a little more discussion-driven, we're going to ask people to move. If you're sitting in the back, to move to the front. So we want to try to fill up the front seats as much as possible. So yes, all of you back there, and all of you back there, if you can move to the front, please. So my name is Tony Ochoa. I'm with the Latino Commission on AIDS. Specifically, I work with National Latino AIDS Awareness Day. Has anyone in the room heard of NLAD or know of the National Latino AIDS Awareness Day? Great, that happens every October 15th. So that's our push for social marketing, kind of making our communities a little more aware on the Latino side. The way we've kind of structured the panel today is we know it's titled Stigma in Immigrant Populations, African Latino Perspectives. And I think it's kind of interesting how oftentimes they lump African Americans and Latinos together in this very similar type of community. But there's obvious differences amongst us that I think we should be cognizant of, even though we're oftentimes put in the same pool, right? So, and kind of hosting this panel today, we hope to kind of touch on some of those similarities, but also really understand how they're different and why it's important to realize those differences, just so that we're effective in really delivering the messages to combat stigma with the given communities we're working with, right? There was something that was brought up during the presentation that Nick presented, where he said that 48% of Hispanic Latinos said that they believe if a person is contracted with HIV or becomes HIV positive, it's their own fault, right? And to me, that really piqued my interest because as a community, Latinos tend to be very communalistic, right? They believe that they're supported by their communities. But if they're saying that it's their own fault if they become infected or the person's own fault if they become infected, what is that saying about the population, and how should we deliver messages to make sure we change that in the communities we're working with, right? So I wanted to kind of set that as a platform for our speakers representing. The first person we're going to have speaking is Dr. Sluzki, who comes with a plethora of experience, which you could read from his bio here. I'm going to read a little bit, the first couple sentences, and then I'm going to add a little personal tidbit that I asked him about when we were having a second to chat. But he has a Master's of Science degree in Health Sciences from the University of Limburg, a Master's of Public Health degree, concentration in International Health and Maternal and Child Health from the University of Arizona. What was that? I was reading the second. I'm sorry, I was reading the second. So now you have a prelude to what our second panelist is about. But that's not the person that's going to speak now. I hate mics, so FYI. Yeah. Yes, please do. So, our hermano here, Dr. Sluzki, was born and raised in Buenos Aires, Argentina. He received his MD degree from the University of Buenos Aires School of Medicine and his psychoanalytic training from the Argentine Psychoanalytic Association Institute of Psychoanalysis. He was trained in Family Therapy and Mental Research Institute in Palo Alto, California. He was a core member of the team that developed the pioneering Department of Psychiatry and Psychiatric Residency Program and the Gregorio Araoz Hospital under the leadership of Professor Mauricio Goldenberg. And I don't want to continue reading it because you guys can see it here, but an interesting tidbit about him, he really understood the value of culture when it comes to integrating that to health services and, in the hospital setting. So he went about introducing a multicultural component to a clinic he was working with in San Francisco to make sure those needs were met, and we address those barriers when providing services in the health field for the communities you work with. So with that said, I'd like to introduce Dr. Sluzki.
Hello. Let me start by bringing a very interesting statistics that appeared in the most recent Lancet. The Lancet is the #1 source of medical and public health information from England, and in which they compare the prevalence in adults of HIV in adults and in the specific population of MSMs. And the first column is Sub-Saharan South Africa. The tallest column is the Caribbean. And the next one, if you count from the left, the number 1, 2, 3, 4, 5, is Central and South America. Notice the disproportion of the prevalence of HIV and MSMs as compared with the general population, much more than, for instance, in Sub-Saharan Africa. It's not news. We know that it has spread in the general population in Sub-Saharan Africa much more. Nonetheless, it's a good point of comparison. We are not touching here the intravenous users population that generally is much more difficult to detect and to study. But statistics is a study of means in general, not of the nuances of the complex picture from the sociocultural viewpoint and even from the different components of a population. No? The prevalence in the overall population in Central and South America of HIV AIDS population is 5 per thousand, a bit less than 5 per thousand, which is comparatively low as compared with other countries. Of course, if you focus on Belize and on Guyana, on Suriname, it will go 1% or up, and then our colleague is going to be talking more in detail about that. And if you put a specific accent on MSMs and intravenous drug users, it rockets. But we say, if not, it's only 0.5% of the population. It means 1.4 million people in Latin America living with HIV and with AIDS. But of course, in addition to that, the discussion, even the research on the subject, is filled with booby traps and with contradictions of different kind. In a very recent publication of a study done in Argentina with 1,200 people living with HIV/AIDS, 94% of the interviewees stated that they have been stigmatized and discriminated against in the previous year. At the same time, 80% of those interviews say that they never shared their diagnosis with others. Fantastic. High experience of discrimination and high experience of secrecy at the same time, which points out to issues that were touched already in the morning. Indeed, the double layer of issues having to do with the inner stigma, high prevalence of inner stigma in HIV/AIDS population, and the external experience of stigma. And it gets combined. That is, it's very difficult to discriminate between the inner, what we bring and read in the world, and what the world tells us and talks to us. And of course, the more the world ignores us, the more we feel that by ignorance, by ignoring, they discriminate against. The less sensitive they are to the specific nuances of, for instance, HIV/AIDS, the more the experience is one of exclusion and therefore of discrimination. So the boundaries between the narrative of the inner world and the narrative of what is going out there is extremely blurred. That is why, of course, destigmatization entails a double job. One job is dealing with the internal front, so to speak, that is, with people with HIV/AIDS, many of whom have been previously stigmatizing the HIV population, creating that very curious trap of suddenly remember that what the famous philosopher Pogo said, I discover who is the enemy. The enemy is us. And that's in a cartoon that was made famous because of that. It's all right. And I did it wrong. Oh. We move. Yeah, okay. Thank you. Thank you, boss. So it's a complicated world, no? Thank you. So imagine the complexity of the world, of the outer world, who in some countries, in 76 countries, homosexuality is illegal. From Afghanistan to Zimbabwe, to go from A to Z, 76 countries, and in 5 countries, homosexuality is punishable by death. Now, and that is something that is talked in the media. It's not something that, because we don't live in Mauritania, Iran, or Yemen, or Sudan, we don't hear about it. No? The other side, there are countries that are constitutionally protecting against discrimination. 7 countries. But they are protecting against discrimination for employment. Whoops, we go to 54. So look at the interesting evolution, no? And marriage for same-sex couples, 11. But recognition of same union, 24. So there is an interesting shift that if you follow throughout time in these last 20 years, you find this shift in the others component of the phenomena of stigmatization, of reduction of stigmatization. Adoption of children from same-sex couple, 15. That goes from Argentina to Uruguay, to go from A to U, but including Brazil, including Mexico in several districts, but just to mention Latin American countries, of course, and UK, etc., etc. Okay, so one of the simultaneous assaults on prejudice that I found interesting, and that it is done each time more forcefully, both in the Latino population and more specifically in some of the countries that I've been working with and I've been exploring. And I will present the information related to Argentina 1912, which Argentina is a rather advanced country from that perspective in terms of their policies. Those are in good part is going public, and public, as Monty Python, remember Monty Python used to say, total frontal nudity. That is telling you as is directly. First, there's a publication on sexuality that is widely distributed. Wood pennies for demonstrations of use of prophylactic that is distributed in all the schools and high schools and intermediate schools. Dispenser of free prophylactics in many places. Stickers for free prophylactics that are in many other shops of every kind. Themes that when I was young, you don't even, when you went to the drugstore to get one, you said, would you give me and there is this is a series of sheets for school teaching of care in regard to sexuality. This is historical social facts. It's history of the reduction of biases and prejudices against open talk of sexuality. The next second sheet is reproduction, pregnancy and contraception, anticonceptive methods, etc., etc. The third one is sexually transmitted infections, and all of these are guidelines that are used on a regular basis. The fourth is rights of young people and how to exert them. No? Cómo hacer valer tus derechos, which is in itself a very interesting propaganda that deals with assertiveness in general, that parents not always enjoy very much, because it also tells adolescents, you have a voice, you are a person. Booklets for teachers that help the teachers carry on in their class, 16 pages. The books for women who are HIV positive, and these are books that are distributed to all health providers. I'm not saying that this doesn't happen here. What I'm saying is it happens very much broadly and openly, and those are methods that reduce both sides, that both the public the public construction of the other as other alien, other different, other to mistrust, other dangerous, and the self-image of people who are living with AIDS and HIV. This is another one for health providers working with transsexual fundamentally. These are posters that, except in the year in which there is elections, when there are elections, all the streets are covered with electoral things. Well, the same happens here, really. You know? The television kills you with political advertisement. Otherwise, this appears on a regular basis. Voluntary testing, posters in regard to the use of prophylactic, posters for general populations on diversity. That's an interesting effort done in order to de-alienate the other. The other are us. And material for people living with HIV. So good part of the difficulty in both the different Latin American countries and in general in this work is how to create a homogeneous militancy, to incorporate melt the two images, the image that it is projected from the image that we receive from the general public. If there is a dissonance, militancy is required. Otherwise, the other internal shift is to become, to embody the experience of being victimized, of being stigmatized. Thank you.